Good morning, everyone. Welcome to Grand Rounds. This morning, we're very excited to welcome Dr. Sakshi Dua. Dr. Dua received her medical degree in India and completed internal medicine residency and chief residency at Good Samaritan Hospital of Johns Hopkins University. She then completed fellowships in both pulmonary diseases and critical care medicine and in lung transplantation at UNC Chapel Hill. Dr. Dua is an associate professor of medicine and medical education here at Mount Sinai, where she's heavily involved in medical education at all levels of training, also demonstrated by her positions as the fellowship director for pulmonary critical care medicine, medical director for the Fellows Ambulatory Pulmonary Clinic, and one of 2 faculty development facilitators of the Institute of Medical Education for the Mount Sinai Health System. Additionally, she holds positions on several educational and training committees of the Association of Program Directors and the American Thoracic Society, and participates in annual medical education mission trips to Africa. Dr. Dua's medical education interests include trainee wellness, small group teaching, delivering effective feedback. A very warm welcome to Dr. Dua.
Thank you so much for that intro, and thank you to the Department of Medicine for inviting me today. And I hope by the end of this hour, you will be thanking me for giving you practical tips on time-efficient teaching and giving effective feedback to maximize your impact with your trainees. So with that, I actually don't have any conflicts of interest. In fact, I often worry that I cost my division chief, Dr. Powell, way too much money for being here. So for the outline for this next 45 minutes or so, we are going to discuss benefits and challenges of clinical teaching. Then I will introduce the 1-minute preceptor model of time-efficient teaching. We will define what is feedback and then acquire a framework for giving effective feedback. So let's start with the benefits and challenges of clinical teaching. Who benefits from the experience of teaching in a clinical setting? One could argue you could have benefits to patients, to learners, and to educators. So what could potentially be the benefit to a patient to come to a teaching hospital versus non? You can imagine that patients might perceive that there's more time to discuss their history, more minds at work to improve their care. You know that our learners are available for follow-up discussions, so more attention is paid to the patients. And with no offense to all the gray hairs on this call, younger learners may actually have more innovative ideas, and the patients might actually perceive that. Then what are the benefits to learners? This is kind of obvious. They get a broad and varied exposure, something you can't get just from sitting in the library with a textbook or in the post-pandemic world, sitting in a Central Park bench with an iPad, or even in a simulation lab, right? They get longitudinal observation. Also, remember, they're learning psychosocial care as well. And the most important, how you and I learned our medicine, not just by knowing medical knowledge, but by applying those theories, is developing critical reasoning skills. And this is my favorite. This is why we do what we do. What are the benefits to educators? Well, I get to engage in formal, ongoing learning. I can't teach if I'm not up to date. So I'm forced to stay current on knowledge. And then I'm able to see more patients than I could do alone because I have learners that I delegate tasks to. And finally, if someone's watching me, I have to behave, right? So we role model behavior for the others to reinforce our own good behavior. So as Sir William Osler said, to study the phenomena of disease without books is to sail an uncharted sea, whilst to study books without patients is not to go to the sea at all. So this is why I can't emphasize enough the benefits of bedside teaching. First of all, we can instruct the attitudes around patient-centered care. We define the culture of our team at the bedside. We are able to align shared expectations, not just between patients and doctor, but also between different learners and the team. We're able to observe how our team members interact with the patient. Also remember, legitimizing the learner as the patient's doctor is really important. We're able to make sure that all the data that our learners are collecting are accurate. Then we can assess our learners' interpersonal and communication skills. We're also able to show our patients how much intellectual and emotional effort is going into taking care of them. Also, making our learners comfortable at the bedside can only occur at the bedside, not in the library, not in a sim room, and not on an iPad. And finally, assessing our learners on the spectrum of supervision to autonomy can only occur when you're observing them by the bedside. And also remember, modeling behavior on how to correct errors, how to give bad news to patients, this can only occur at the bedside, although one could argue sim labs are also good at it. So then why don't we do it more? Why aren't we doing more and more at the bedside? Well, I don't know about you all, but I only have 24 hours in the day. So time, and time. We have so many competing priorities. We have to complete notes. We have to maintain productivity. We have admin tasks. And some of us magically have to find time to do research. For our trainees, you know that they have work hour limitations. They have to document a lot. Some of them have to do clerical tasks. Also, some of us may feel a little lack of confidence or competence in teaching. Also, teaching to learners at various levels is challenging. If I'm rounding on pulmonary consults with a fellow, with a resident, and a medical student, teaching to a medical student level might be too simplistic for the fellow. Teaching to a fellow level might be too complex for the medical student. And then finally, if my learners are not interested, I'm just going to pack up, go home and do yoga instead, right? So there are a lot of challenges to this. In fact, the perceived barriers in literature can be divided into personal, where there's a misalignment between expectations and our skill level. It can be environmental, like I mentioned, time, competing responsibilities, and also what about institutional support for teaching? And then in this post-pandemic world, I would argue physical space. And then finally, interpersonal, aligning patient expectations, and also this tug of war that's always occurring between learner autonomy and teacher control. Okay, so just to summarize this portion, I would say while the benefits of clinical teaching are immense, there occur many challenges to consistently engage in it. So therefore, let me introduce the 1-minute preceptor model of time-efficient teaching. But before we do that, what actually makes an effective teaching encounter? What's the literature out there? Well, first of all, this effective teaching encounter creates an environment that's motivating to learners. It explores their pre-existing knowledge. It provides a conceptual framework for ideas and facts, something they can't just get from sitting in the library and reading a textbook. And then it facilitates learning with understanding through active involvement. So look at these words: motivating, conceptual, active. So then how would you make this happen in your teaching encounter? Well, first of all, do this thing: set expectations early. At the beginning of your learning relationship, for most of us, it's a Monday. So it already occurred yesterday, okay? So at the start of your rotation, please set expectations and basically use these words. This is a safe environment. So remember, psychological safety is very important for learners. This is a safe environment. I want to meet with you one-on-one to set tailored goals for this rotation. So setting expectations early. Finally, ask them what their goals are for this time together. What specific goals do you have of our time together? What are you hoping to improve or learn on this rotation? And finally, please share your expectations. Do not expect your learners to mind read. It is not fair, right? So basically tell them, during our time together, I expect you to. Like for me, it would be pre-round on these patients, gather their data, et cetera, et cetera. And also you could say, if they're coming around a second time on a rotation with you, you could say, you know what, you've been consistently performing a majority of skills that I expect at this level of training. Now I want you to start focusing on future, okay? So this is basically the whole idea of, by failing to prepare, you're preparing to fail. Your teaching encounter is not going to be effective if you didn't do the set expectations thing at the start of your learning relationship. So then now let's actually go to the 1-minute preceptor. It is the most researched and reported method. It does involve 5 micro skills, and this is what they look like. So the case presentation is the case presentation. That's your learner. But what are you doing? You are going to take 2 steps to diagnose your learner and 3 steps to actually teach them, okay? So the 2 steps you take to diagnose your learner are going to be to get a commitment from them and then probe for supporting evidence. In your teaching aspect, you're going to teach one general rule, reinforce what they did right, like pat on the back, and then correct the mistakes that they made, okay? So I will go through each step one by one, so don't worry about remembering all of this information. In fact, what do we know about the 1-minute preceptor based on literature? We know that actually it does increase your teaching effectiveness, your teaching efficiency, and yes, it improves the quantity and specificity of your feedback, and it gives them motivation for outside learning, while not really declining patient satisfaction, because that's important. And also, most importantly for most of us, it doesn't change the visit length. So it's not as though you're going to be extending your encounter because you did this 1-minute preceptor model. In fact, it has been studied both in and outpatient settings. And yes, you can use this on medical students and residents, and I would argue fellows as learners. And when you use residents as teachers, this can be applicable. So for me, my fellows as teachers, okay, and also as faculty, which is what we're doing today, I really hope there's residents and fellows on this call today. Okay, a little bit of a misnomer here, and I hate to disappoint you. I know that it's called a 1-minute preceptor, and I know I sold it that way, but really it is a 10-minute preceptor. I am so sorry. Okay, now the 6 minutes that you spent were on case presentation that your learner did, right? There's nothing you can really do about that. The 3 minutes would be you diagnosing your learner. Remember, I said those 2 things you're going to do, and I'll go over those steps with you, but this is you questioning, okay? The reason why it's called 1-minute preceptor is really it's that 1 minute that you're spending teaching them. This is a discussion. This is your teaching. So that's why it's called the 1-minute preceptor. Sorry to disappoint. It's actually 10 minutes. Okay, so what are those 5 micro skills again? Diagnosing. These are those 3 minutes I said. Getting a commitment and probing for supporting evidence. And then this is that 1 minute that kicks in. Teaching a general rule or reinforcing what was done right and correcting mistakes. So let's go over all the steps one by one with examples. So number 1, you diagnose your learner. How? You get a commitment. Why? The rationale is it sets the stage for an interactive learning environment. It provides direction for your teaching and makes your learner an engaged learner rather than a passive observer, right? How would you do this? Well, as an instructor, you initiate the question, what do you think, da, da, da? It can be anything around diagnosis, workup, or plan, okay? So a helpful approach would be, what do you think is going on with this patient? What do you want to do next in the workup? What do you want to accomplish during this hospitalization or clinic visit? What's not helpful is saying something non-specific like anything else, because you're not really getting a commitment by saying that. Or giving them a lead, like, did you ask? Because you're giving them a direction to anchor on. Or giving them the answer. Sounds like da da da. That's already shutting the door on getting a commitment from your learner. Next would be once your learner says something, you have to probe for supporting evidence. What is the rationale? Well, it provides an insight into the learner's critical thinking. It allows you as a teacher to identify their gaps. It gets to their underlying clinical reasoning. Why did they commit that way? And it differentiates a lucky guess from a well-reasoned logical answer. And so how would you do this? You would ask questions to discover the underlying rationale and keep your poker face. Avoid any instinct to agree or disagree right away once they gave you a commitment. So let them go down that rabbit hole if they dug a little bit. So what would be the helpful approach here? Okay, they said something, right? So now you're going to ask, well, what were the major findings that led to your conclusion? Or if they actually made a anchoring diagnosis, ask them, what else did you consider? The good old differential diagnosis. And then if they actually made the wrong choice, do ask them, why did you rule out that other choice, which would be the correct choice? What's not helpful is immediately saying, I disagree. Do you have any other ideas? Because you're not really probing into supporting evidence. Or again, giving away the answer. This seems like a classic case of da da da. You didn't get to their underlying reasoning this way. So this is the 2 steps of diagnosing the learner. Finally, you are in your 1-minute preceptor mode. This is where you teach a general rule. The rationale is instruction is much more memorable when there's a general rule, and it can be anything around symptoms, exam, differential diagnosis, evaluation of patients, treatment, or resources. And how do you do this? Well, teach a general rule. When this happens, do this as a general rule. So just to give you an example, because I'm in pulmonary, I would say, when the immunoglobulin E is completely normal, this makes allergic bronchopulmonary aspergillosis very unlikely because it kind of rules it out almost. Okay, so that's a general rule. What's not helpful is me saying, oh, this patient obviously doesn't have ABPA. Why? Did I teach a general rule? Next, you want to reinforce what they did right. Why? Because skills in learners that aren't well established yet need to be reinforced. Be specific, not just a general praise like well done. What did they do well and what effect did the good work have? And so how you would do this is give a very specific feedback to reinforce their desired knowledge, skill, or attitude that you appreciated. You know, I appreciate that you considered the possibility of allergic bronchopulmonary aspergillosis in this patient with severe asthma. I reinforce what they did right. Not helpful be, you're right, good decision. What good decision? As a learner, I don't know what you're appreciating right now, so be specific. And finally, you have to correct mistakes. This is kind of obvious. If you don't address, they will occur again. So, if somebody discharged patient on like wrong kind of inhalers, okay, next time make sure you select the correct COPD inhaler prior to discharge. And here's a list of what would be the correct COPD inhalers. Rather than saying, you did what? Or what were you thinking? Because that is not the correct way to correct mistakes. And so to really summarize your 1-minute preceptor with the 5 micro skills, number 1, you diagnosing the learner by getting a commitment, by asking, what do you think is going on? What investigations do you feel are implicated here? What do you think needs to be accomplished on this visit? Next, you will probe for supporting evidence because you're looking at rationale behind their thinking. What are the major findings that led to your conclusion? What else did you consider? And what made you choose that particular choice? Next, you will teach, this is your 1 minute kicking in, teach a general rule, keep it brief, focused on identified issues. In fact, avoid anecdotes or idiosyncratic preferences. That's not a general rule. Reinforce what was done right, so you be specific. And finally, correct errors. Now, don't embarrass your learners, consider the appropriate time and place for it, and also start with learner self-reflection. What do you think that you did right or wrong during this encounter? Be very specific. And then finally, consider language like, that was not the best choice or idea, rather than saying that was a bad choice or idea. Now, for those of you who haven't had enough coffee today and feel like you're about to doze off, go ahead and take a screenshot because this pretty much summarizes the first half of my talk, okay? So the final tips I want to leave you for expert teacher would be enthusiastic, set realistic expectations, create an active learning environment, ask open-ended questions, make sure you're an active listener, give time for response. 5 seconds, that felt like forever, but yes, give time for response, and then admit when you don't know something, give advice on how to find it, and remember, you're a role model more than just for medical knowledge. In fact, literature does show that it's not how much a teacher knows that makes their students appreciate them, it's their attitude. That's the number 1 tip. All right, let's pivot to feedback. This is my second half now. A quick question to yourself, a self-reflection exercise. Do you regularly set and share expectations around feedback with your trainees? And then do you regularly provide face-to-face verbal feedback, either individually or with your entire team? Something to think about. So let's just define what feedback actually is. Every single word in this definition is quite significant. First of all, it's a supportive conversation. It's two-way, okay? It clarifies the trainees' awareness of their developing competencies. It enhances their self-efficacy for making progress. It challenges them to set objectives for improvement. So even though we're calling this feedback, do you notice the feed forward? It's very forward thinking. And finally, it facilitates the development of strategies to enable that improvement to occur. So really, you're acting more like a coach when you're giving feedback, okay? So what does it take to do effective feedback? Well, first of all, you have to observe your trainee. You have to plan it. And then you have to practice it. It's like muscle memory. The more you do feedback conversations, the better you get at it. And then you have to be flexible, you have to pick the time and place for it. Sometimes in the heat of the moment, it may not be the appropriate time for feedback. Allow things to cool down and come back to it. So then what are barriers to doing effective feedback? And I will not leave you high and dry. I will give you potential solutions for each of these barriers. Number 1, as we mentioned with teaching, also time constraints. Number 2, and myself included, by the way, faculty might be resistant to giving negative feedback to trainees. We have long-term relationships with our trainees and we feel like we don't want to jeopardize them. Also, we might feel, trainees might be resistant to getting negative feedback. And finally, we might be overwhelmed with what to address during a feedback conversation. So, for time constraints, I would say if you establish a culture where feedback is not only just expected, but it's actually desirable and it's an essential component to teaching, part of your work culture should be such that actually the trainees are coming to you asking for feedback. This is how much it needs to be done. And with 360, why not turn it around and say, I want you to give feedback to me of what I could be doing to improve our time together and your learning. Now, for faculty who are resistant to giving negative feedback, if you ground your feedback in observed actions and decisions, so specificity that you observed, not about their personality or maybe behavior, but more about actions they took and decisions, then yes, you'll be able to give very objective feedback without that emotional ring to it. Finally, we love to give millennials and Gen Z a hard time, but really, these trainees actually are your ally in self reflection. They do love to self reflect. So consider and engage your learner as an ally in self reflection. And if you're overwhelmed by what to address, remember, feedback is best consumed in small portions rather than a banquet. And the pandemic took care of banquets. So small portions it is. Okay. All right. One thing I want to make sure most faculty know that feedback and evaluation are not the same thing. And this is the one thing I feel our faculty are most confused by. Feedback does not equal evaluation. What is feedback? Feedback is formative, evaluation is summative. What do I mean by these fancy names? First of all, feedback is an assessment that is made for their learning, whereas evaluation is assessment made of their learning. Feedback presents objective information to help a learner improve relative to themselves. Who are you comparing them to? To themselves. Okay. Whereas an evaluation is actually a judgment that you make on how well a learner met a goal or a standard. Therefore, feedback will be neutral statements using verbs and nouns. I observed that you made this decision. That's feedback. Whereas evaluation is a normative statement with adverbs and adjectives like this trainee performed at a level of whatever. Okay. Also, feedback, remember, is focused, whereas evaluation is usually comprehensive. Finally, feedback is something that is timely, so it occurs day to day. You can't wait 2 weeks before giving feedback about something that happened today, all right? Whereas evaluation, as you know, is at scheduled intervals. So just to summarize definition of feedback, information that you give in the moment, and I would argue that could be within the next 24 hours and definitely within the next 48 hours. Evaluation, on the other hand, will be summative information based on multiple data points that you collected during your entire learning time together. All right, then let's acquire a framework for actually having this feedback conversation. Now, this should look familiar to you. Set expectations early. Remember, I already told you setting expectations anyway on Monday, might as well set expectations around feedback. So this looks familiar. On Monday, when you start your learning relationship, again, this is a safe environment. I expect that all of you, if you're in a team, will actively give and receive feedback from me and each other. Really normalizing feedback, making it part of your workday and culture, and really soliciting feedback yourself. Then you elicit goals from your learners, specifically with learners who've been with you before or who've come back on a rotation with you. What feedback have you received previously from others? What is it that you want to work on in terms of moving forward? What changes were you hoping to make so that you can actually give them feedback about a focused content area? And finally, please share with them what you expect during this day or week. I expect you to, because it's not fair to give feedback to people that you haven't set expectations with, because they don't know. We are so different in our work styles, rounding styles. We should not be expecting our learners to mind read. Now, remember that feedback is a conversation, so it's two-way. So let's actually get into what feedback, how it should be done, acquiring this framework. Remember this old feedback sandwich where we would sandwich the bad between the two good? On the whole, things are fine, but you were terrible at this. But this was really good. Nice chatting. So this is now an old model of giving feedback, sandwiching the bad between the two goods. The new and better feedback sandwich is what we call ask, tell, ask. Why do we do this? It's more learner-centered, it's active and interactive, it certainly avoids any assumptions or judgment on your part, and it promotes self-reflection by your trainees. And therefore, start with your ask, okay? Why do you want to do this ask? You want to ask your learner to assess their own performance because it begins a conversation, it assesses the learner's level of insight, it promotes self-reflective practice. How would you do this? How do you think that went? Ask them first, okay? How do you think you did during that encounter? Or how do you think you're doing this week? So this is setting the stage for a feedback conversation by asking. Now that they've said something, you have to tell, right? But how would you tell? First, you have to react to what they just said and therefore normalize it somewhat. If they're anxious, tearful, joyful, just normalize and react to it first, and then use very descriptive but non-evaluative, non-judgmental language to be very specific and avoid generalizations, because you only want to use what you observed in their actions and decisions. So, if somebody said, I'm really sorry, I was sending you notes so late to co-sign, or I was so slow with my pre-rounds that I was never on time, just normalize and say, you know what, it's common for interns to struggle with efficiency in July and August. Then always lead with, I observed that, okay? Always lead with that. When you're telling somebody what you observed, I observed that. Not starting with the you, me. And then finally, you can say, I observed that, you missed asking about that vaping history. What if the patient came with EVALI or something, right? Versus your history was incomplete. So observed decisions and actions. And then you're going to close the loop with an ask. Ask, just like we tell patients complicated instructions and we have them repeat back, ask your learners understanding of what you just said. And then ask them for strategies for improvement. Now you're going to take off your faculty hat and put on your coaching hat and say, let's develop an action plan for improvement, and then commit to monitoring improvement together. So what could you do differently next time? This is you asking them, okay? Or can we check back again in a few days to see if we have a monitoring improvement plan together? And finally, I would say this is kind of the slide that summarizes everything I told you about feedback. During the feedback session, this is you setting the orientation and climate by selecting an appropriate time and place, not in the corridor, not embarrassing people in front of their teammates if it's something critical, in a relaxed atmosphere, have something already ready in your head before you have a conversation. Then the ask portion. You will ask your learners' perception of what was done well, what could be improved, how that thing went that you did together, okay? Now you're going to do the tell part, where you are going to give them the diagnosis of what you saw and the actual feedback, where you offer your response to your own observations. I observed that, and place it in the context of the goals of your rotation. Finally, you will do the ask again, where you will ask your learner for ideas first upon which they can improve, and then give your suggestions on how they can improve. And then, of course, you will apply this to future problems, and then do a closed loop where you will review these specific behaviors and the consequences of this improvement plan. So for those of you who still don't have enough caffeine, this is a screenshot you want to take about feedback, the ask, tell, ask. So final tips I can give you for improving feedback would be, feedback has to be frequent. It has to be timely, because if it isn't, it's not feedback. Then you're just doing evaluation. It has to be balanced, has to be specific, okay, something that you specifically observed, and allow your learner to self-reflect, which is why we always start with the ask. And then be conscious of non-verbal communications. I would argue in the world of Zoom, you can't tell anything what's happening from neck down, but you can still tell how I'm acting and behaving. So it may be giving unintentional feedback if you're using more body language. Now you have to close the loop with evaluations. Remember, as faculty and residents, you're not off the hook completely, right? You're often asked to provide a summative evaluation to your learners. This is your end of rotation evals. Make sure that you align your evaluation with feedback conversations that you've had with the learner. Remember, we don't want to talk about people without talking to people, right? So please make sure that you are aligning your evaluation with the feedback conversations you've had. Also, a mid-rotation feedback would be great because then you give a chance to your learner to improve upon things so that the final evaluations improve, okay? And remember, in both your feedback and evaluations, you must consider feeding forward. This is future thinking. You are a coach. Provide very specific, achievable next steps for each learner. So just to summarize, really align yours and your learners' expectations early. Do that Monday morning expectation talk, not only around your teaching, but around feedback. Make sure that the feedback is a conversation. You're not talking at them, you're talking to them, and always start with an ask on how they think they're doing. Tell them with observed decisions and actions, and finally ask how you could together come up with an improvement plan. And yes, you are a coach here. You provide next steps and you as you conclude your learning relationship. In this ask portion, I would also argue, why don't you go ahead and ask, how could I be doing better? As your faculty member, how could I be improving as a teacher? And with that, I would like to put a little tiny plug for the Institute for Medical Education. We do a lot of these as modules separately. So time efficient teaching that I talked about, the 1-minute preceptor, we have another one called the SNAPS model, like snaps. We do another module for that. And then we do obviously effective feedback. We do evaluations one, how to write good evaluations rather than just saying, keep reading more, right? And then another one is on letter of recommendations. So we have these 5 ready to go modules. Just go to our website at IME and you can ask for faculty development on any of these 5 modules. You can email me directly if you want. And with that, I would really like to acknowledge my division chief, Dr. Powell, who lets me run wild with my medical education pursuits. I do want to acknowledge these 3 individuals in pulmonary, Dr. Di Fabrizio, Che, and Chen. During this pandemic, they have taken on the burden of so much clinical work in the pulmonary side of our division. I call them my own emotional PPE, okay? And finally, my team at IME, Rena for her guidance, Vicky for the generosity of all these materials that we developed together, and Olga for disseminating these materials. So with that, I can leave you with some resources, Meta Portal publications on feedback, some YouTube video if you wanna watch, basically gives you beyond great job, and then some references if you want that I can always share with you after. So with that, I'm happy to take any questions that you might have.
Thank you, Sakshi, very much. Wonderful talk. I think we have some comments and questions in the chat, I think.
Yeah, so Marguerite says, chess coaches say a stronger move would have been very nice. Nice way to give some feedback, right? Rather than going with bad, not the best, right? You were not the best at this, rather than saying you were bad at this. So yeah, a stronger move would have been da-da-da. So you're being a coach. I love this. Leslie says older patients who are 70 to 90 are too challenging. They take time, multiplicity, simultaneous, cost goals. They're all different, and attitudes of teachers are obvious. Older patients get bad time attention list of meds. Yes, lots of goals. Negative from faculty are not too expensive. Leslie, would you like to expand on your comments? I do understand the time challenge and the multiplicity and simultaneous multiple things you need to be addressing. Okay, I'm going to go to the next one. Frederick Sherman says, does the 1-minute preceptor or the ask, tell, ask sandwich deal with anticipated errors? For example, the general rule is for auscultation of the lungs to be done with the chest piece of the stethoscope placed directly on the patient's skin. Yet, we all see residents, fellows, and attending placing the stethoscope over one or multiple layers of clothes. How do you deal with the likely use of this unacceptable technique in your learner's future? You say it is likely you will see this technique used in the future. Will you use it? Oh, I love this. This is amazing. You are grabbing a teaching opportunity right at the bedside or outside the patient's room. This is a great way to use both anticipated kind of general rule, etc., especially with medical students. This is absolutely wonderful. Thank you, Frederick Sherman, for this comment.
Other comments, questions?
Oh my God, I talk fast because it's only 9:07, and I thought that this talk was like really long because I really combined 2 topics in one. Yeah, Leslie says old patients who are older, like 70 to 90, basically are expensive time-wise and have multiple challenges simultaneously. Yes, very. And so, sometimes depending on the stage of the learner, say if it's a medical student, we have to be very appropriate in what patients we assign to them, depending on their level of training, right? So if I have on my pulmonary consult team, simple to complex patients, and I have a fellow resident and student with me, of course, I'll be very mindful of my own time consumption and make sure I assign appropriate patients to medical students, for example. So I totally get where you're going with how much time consuming it would be to give a very, very, very complex patient to an early stage learner. Andy Dunn, do you recommend asking for feedback on your performance during your feedback sessions with learners? Absolutely do. I actually closed the loop with the Ask Tell Ask with a 360. In fact, if you can believe it, when I went in Dr. Powell, my division chief's office for my annual faculty appraisal, I actually asked him if I could do a 360 and evaluate him. And he said yes, and we did it. So if I can do it with my division chief, you can certainly ask your learners to do it with you. Dr. Brown, patients are upset when all their issues are not addressed. How do you deal with unhappy patient or the disruptive patient? Oh, I love this question because this is a perfect teaching opportunity for you to take the lead, role model behavior, and have your learners be a passive observer. Remember, this is where they're going to learn how to deal with difficult, disruptive, unhappy patients where errors were made or something was missed. So Norma, thank you for this. This is an amazing teaching opportunity of role modeling behavior. In fact, I do always say, in critical care settings, right? I may not actually have the time to stop doing what I'm doing for the patient in a critical scenario to make sure my learners are getting it. So what do? I talk out loud. So I basically think my thoughts out aloud so they can hear my kind of rationale and reasoning while I'm dealing with a critical scenario. And yes, role modeling behavior. So thinking out aloud and role modeling behavior as you address unhappy patient or disruptive patient is a great seizing of the opportunity of teaching. So carpe diem.
Anything else? Let's see. Not sure there's any more coming. It was great to see you role model your enthusiasm for teaching, Dr. Dua. That was terrific to see. You practice what you preach, obviously. So this is great. So thank you. Thanks, everybody. As Marguerite's saying, a fantastic talk, Sakshi. So nice seeing everyone. Have a great day, everybody. Enjoy.
Yes, and my superpower is talking fast. So I just gave you back 20 minutes of your day. Use them wisely. Thank me later.
A big thank you, Sakshi.
Have a great day.
See ya.
Okay, bye.